in notes. And I'm intrigued because if you video a talk, it takes you, what, 1 hour to watch a 1 hour talk. How does that speed things up? Okay. I recommend taking some notes. I'm saying that because the exam comes from the lectures. And all the statements that are made in the talks are basically statements that are used in creating the exam. So it's worthwhile to try and pull those bits out, which is much shorter to do while you're obviously sitting here than to go through it all afterwards. Some of the stuff obviously needs lots of drilling into your memory, which is why we repeat it. And it all comes from the books that Carl showed you, the surgical neuroangiography books. That's basically what we're trying to make a little bit easier for you to understand. So if you need to check anything, it's in those books. Good. So we're going to talk a little bit about the anterior choroidal artery. We're going to look at 4 things. Just again, the repetition of the phylogeny and ontogeny, imaging, the territories that are covered by the vessel, and some of the risks. So you've seen these pictures. Let's start with this one. And this is at the stage of the amphibian, right? So we don't have a visual cortex yet. And the carotid divides into its 2 main branches, the cranial division and the caudal division. There's no middle cerebral artery yet. Oh, sorry, I pressed the wrong button. No middle cerebral artery. But what we do have is this artery that in the amphibian is called the posterior teleocephalic, and then later on in the reptile called the inferior cerebral. And this is the area that's supplying, the vessel that's supplying the cortex at the back part of the telencephalon. The caudal division of the internal carotid has a little artery, the inferior tectal artery, and that's where these 2 territories are united at the level of the tectum. So we've got a superior tectal branch coming off this posterior teleocephalic artery and an inferior tectal branch that's uniting. If we move a little bit further on, so on this side we have the circle of Willis as it applies to a bird, and then on this side the circle of Willis as it applies in a human. So again, you can see here's internal carotid, comes up, divides into a caudal division, cranial division. The first branch of the cranial division is the posterior teleocephalic artery. And then if we go to the human, carotid artery, caudal division, which is the PCOM, cranial division, and the first branch is the anterior choroidal artery. The difference between these 2 species is that the cortical territory of the posterior teleocephalic artery in the bird, which has now got a big cortical territory for vision, shifts onto this posterior tectal artery, which is the PCA. So in the human, the anterior choroidal has shifted all the cortical territory to the posterior cerebral artery. And the anterior choroidal looks like a small artery, but as you know, the size of vessels doesn't have any resemblance to its importance as an embryonic vessel. If we go to Dorcas-Paget's drawing, so this is at the 9mm embryo stage, about 4 to 5 weeks of age, and here's the internal carotid, divides into a caudal division, which is going to supply the hindbrain, and a cranial division, which is going to supply the telencephalon, and the first branch is the primitive anterior choroidal artery. So at this stage of the embryo, there's hardly a middle cerebral artery. There's these tiny little branches of middle cerebral that are going to, they're really the striate branches. That's the beginning of the middle cerebral artery. But the anterior choroidal is a bigger artery, and it's lying at the junction of the telencephalon and the diencephalon. So it's between the 2. That's important. Why is it important? It's important because of the territories that are supplied. So the anterior choroidal artery, because of its position, is the only artery that supplies the telencephalon the diencephalon, and the mesencephalon. No other artery crosses territories like this. Because of this, in its cranial area, it's in balance with the middle cerebral artery. And in its diencephalic, mesencephalic area, it's in balance with the posterior cerebral artery. But what we mean by balance is it's possible for the anterior choroidal to take over some of the normal territory that the striate arteries would supply. Or it's possible for the anterior choroidal to take over some of the PCA supply. So let's just go through the cranial areas that it supplies. So the telencephalic structures would be the medial temporal lobe, so peripheral cortex, amygdala, and then as we get further back, the perforating arteries are going to go to the caudate tail and the globus pallidus. If we look at the area that's in balance with the diencephalon and mesencephalon, we've got supply to the optic tract, to the lateral geniculate body, and then perforating vessels that are going to go through to the crus cerebri, the subthalamus, the posterior internal capsule, hippocampus as we get to the back, choroid plexus, and then if there's a territory shift, we can add on a cortical territory to the anterior choroidal artery. The normal imaging of the anterior choroidal on MRI can be a little difficult to spot, but on sectional imaging, it's this little vessel here that's going to be really close, wrapping around the midbrain, and then at this point here, disappearing into the temporal fissure to get into the choroid plexus of the temporal lobe. On angiography, it's got a very characteristic little step appearance. So on the lateral view, of course, it's the first branch coming up here after the caudal division of the internal carotid, so PCOM is here. Next branch, anterior choroidal. Yellow vessel, the yellow arrows pointing at the perforating vessels that are coming off, the deep supply. The red arrow is what we call the choroidal point, where it takes this little step, the little kink where it goes into the temporal horn of the ventricle to supply the choroid plexus. And the blue arrow is pointing at the typical choroidal blush that you see in a slightly later phase of the angiogram. And if we're lucky, sometimes we can even see the little perforating vessels coming off that anterior choroidal. Because of its close relationship with the PCOM and the shared balance, it's possible for variations in this area. One of the variations is a combined origin with the PCOM. And you can see here, if we rotate this in a medial direction, we've got a single vessel coming off near this little aneurysm. One is the PCOM, one is the anterior choroidal. And of course, the opposite is true. So where you can have this fused origin of the two, it's possible to have multiple origins. So the branches of the anterior choroidal can come off separately, particularly the telencephalic supply. The supply to the medial temporal lobe can be separate. So if we put all that information into use now, how does that affect us clinically? So let's look at some of the clinical applications of anterior choroidal anatomy. Let's start with stroke. So this is a patient who has a complete carotid occlusion after a night of cocaine use, young woman, has very good PL collaterals, from the posterior cerebral. The vessel manages to get reopened, but the territory that she loses is, of course, part of the supply of the anterior choroidal artery, which was occluded for a long time. She woke up absolutely fine and made a really good recovery. And that was well known. This is the publication from Irving Cooper, published in 1954 in the American Journal of Geriatric Society. What Irving Cooper discovered quite by accident is he was operating on patients with Parkinson's disease. And this was the patient that was popular in that publication. So what the surgeons were doing at that time is the patients had such severe Parkinson's There was no levodopa that was available to treat Parkinson's at that time. So what was done is you do a subtemporal craniotomy, so you get underneath the temporal lobe, get to the crust of the midbrain, and partially section it. So the peduncle of the midbrain, you cut it in half. And that would get rid of a whole lot of motor function, but it would stop the terrible symptoms of the Parkinson's disease. Anyway, Irvin Cooper started the procedure, lifted up the temporal lobe, and he managed to tear the anterior choroidal artery. He packed it off. The patient woke up, no weakness, and the tremor had gone. So he thought this was an amazing discovery. And of course, he'd infarcted the subthalamus area, which is the target for Parkinson's treatment that we use now. But you know from what I just told you that the territory of the anterior choroidal can be very variable. So in that particular patient, it just so happens that there was a predominance applied to the subthalamus, and that was the area of infarction with the benefit, and none of the side effects. But of course, the more of these procedures you do, the more you're going to find the patients who have a big supply to the globus pallidus, or to the visual pathway, or to the internal capsule. And these then the patients were waking up with a dense hemiparesis, loss of vision, and all the other problems of those territories. So the procedure was abandoned. From a surgical point of view, the anterior choroidal is a difficult artery to see. Hopefully in some of Philippe's pictures and the 3D pictures we'll get an idea of that. So this is an old angiogram picture. There's two aneurysms on the carotid, obviously. One we're going to call PCOM because it's coming off near the origin of the PCOM. The other anterior choroidal because it's right near the origin of the anterior choroidal artery. This is the intraoperative picture of that patient. And what I wanted to do is just illustrate this. So this is the right side. Here's the optic nerve, right optic nerve. Clinoid process, the right carotid artery. Here's the first aneurysm, the PCOM, that's just underneath the edge of the tent. And you can see the origin of the PCOM artery over here, and it curves back medially. This is really nice. So from a surgical point of view, finding the PCOM artery is not too difficult, but it's impossible, really difficult to see the anterior choroidal artery because it runs directly posteriorly. So there's the other aneurysm, the second aneurysm. But you can see it's really difficult to look around either side. And even more difficult, once you've put clips there, you cannot see that anterior choroidal artery. And that's why surgical clipping in this area was such a risk for damaging the anterior choroidal artery because you can't see it. So let's look at a different case. This again is a surgical view on the left side. Left optic nerve, left carotid, left third nerve, and I'm just retracting the carotid now because there's the anterior choroidal artery. Just to give the idea of this straight back trajectory of it, which makes it difficult to see. That's the basal artery. Another case, this is a patient again, we're on the left side, left optic nerve, left carotid artery, left PCOM, left anterior choroidal aneurysm with the left choroidal vessel. And again, once you start putting a clip in there, there's the left third nerve, it's impossible to see the anterior choroidal artery. And you can imagine it's really easy to put a clip across that and not know that you've done it. So I mentioned that it's possible for multiple vessels to come off in the region of the anterior choroidal, and this is an example of that. So on the right side, this is the right carotid, and here's in the region of the anterior choroidal multiple vessels, and you can see all of them are going towards the temporal lobe. So this is separate little supplies to the medial temporal lobe. Another example of an operative use, this is a massive skull-based procedure to remove a big tumor from the middle fossa floor. And where we've done that, everything's displaced, and you can see there's the left PCOM artery and the double anterior choroidal artery just above it. And then angiographic pictures showing the same thing. Carotid artery, ophthalmic, PCOM, PCA, and there's anterior choroidal vessels. This one is clearly a little branch to the medial temporal lobe. The anterior choroidal is also an important surgical landmark, and understanding the anatomy is really important in terms of protecting this during surgery. So this is one of the surgical approaches that's used to get to the thalamus area or the midbrain, and it's a transtemporal, transchoroidal approach to the midbrain. So the idea is that you go through the middle temporal lobe gyrus, get into the temporal horn, and then identify the anterior choroidal artery. So that's the landmark that we're looking for. And then you have to know, of course, that you've got to displace the chorioplexus and the anterior choroidal artery inferiorly to protect its little branches, because you don't want to tear those when you're operating. So this is what that anatomy looks like. So this is one of Roton's dissections. Here's the carotid artery, A1, middle cerebral artery, M1. Here's the anterior choroidal. Going back, there's the first step, little perforating branches to the medial temporal lobe. Anterior choroidal going back. This is the choroidal point where it takes a little curve to get into the choroidal fissure, and there's the chorioplexus with the distal artery and the supply to the hippocampus. So this is just the operative view of getting through the temporal horn, displacing the chorioplexus and the anterior choroidal vessel to get to what turned out to be a casinoma in the thalamus. So that balance with the telencephalic and downcephalic, mesencephalic areas is important to look for when you're treating anything in this area. Here's an example of a patient with a carotid aneurysm, and we call it, it's really close to the PCOM, you call it, I guess, a PCOM aneurysm, except we can't see the PCOM vessel, but we do see this vessel here. Looks like anterior choroidal. It's got all the steps of it, and then on the AP view though, it's not in the normal distribution. It's running medially. We'd normally expect the anterior choroidal to go around the midbrain. This one's clearly going in a different direction. If we look at a 3D picture, there's that vessel. If we look on the cross-sectional, there's the aneurysm, there's the vessel. So this has got a choroidal origin, but it's a telencephalic large area of supply of the basal ganglia rather than a small area of supply, and it's coming off as a single branch. Important to see that, because if you're going to treat that aneurysm, you have to know that that's a territory you don't want to lose, so you're going to have to leave that little bit of neck of the aneurysm open. Another example, aneurysm in the same place, anterior choroidal vessel, except it's got this slightly different appearance. If we look at it on 3D, same thing. So those are just illustrations of how the anatomy varies and the balance can shift according to the territory that it's going to supply. What about endovascular treatment in the anterior choroidal territory? So here's an example of a patient who has small choroidal AVM, temporal lobe choroidal AVM. So the anterior choroidal artery is supplying this little nidus over here, and then you can see we've got venous drainage that's probably ventricular and posterior, and venous drainage that's towards the sylvian fissure. On an AP view, there's this area of venous dilatation. Looks like a really nice target for endovascular treatment. Except, here's the angiogram, and you can see there's the typical anterior choroidal artery. There's the little nidus, which is presumably distal to the choroidal point, right? Because it's the chorioplexus that's being supplied. Here's the microcatheter in that anterior choroidal artery, right up to the point of the nidus. So there's the nidus filling, there's the posterior vein, and there's the anterior vein. Looks like a nice target, right? Safe? Not safe? Not safe, right? It's just way too close to the choroidal point. So any reflux in here is going to take out perforating supply in the anterior choroidal. And this is so often the point with anterior choroidal catheterization, is it's really difficult to get into a safe position. Patient presenting with a temporal lobe hemorrhage. AP view, this is the 3D runs, and you can see there's something over here. There's these little bubbles, they don't look normal. Lateral view, same thing, we've got this little bubble appearing over here. If we do an angiogram, and this is a selective run in the anterior choroidal artery, so the catheter is lying here, there's the catheter tip. This is going to be the choroidal point over here. You can see perforating vessel coming off there. This is where it enters the temporal horn. Here's the choroplexus AVN. There's the little presumed rupture point, the little false aneurysm that's bled. So it would be really nice to target that. And in this instance, we're able to get the microcatheter past the choroidal point, right up to this area over here. Fill up the little false aneurysm and deplete it. So the perforating territories have to be preserved. What about the cortical territories? And these are important to identify, right? So you've seen some examples. Normally, the anterior choroidal has this cortical territory of the medial temporal lobes. That's normal. But then we can take over much larger cortical territories that are usually supplied by the posterior cerebral artery. So this is Inthrop's example. You can see here PCOM, PCA, anterior choroidal, which has got a much larger territory over here than we'd normally expect. And when we look at the vertebrobasilar injection, you can see clearly that territory is missing. It's been taken over by the anterior choroidal artery. And if we look closely, you can actually see the perforating vessels coming off the anterior choroidal and the choroidal blush over here. The vessel doesn't have to be that large though. It can be a relatively small cortical territory that gets taken over. So in this view here, we've got carotid artery, very small PCOM, the vessel above, anterior choroidal, goes past the choroidal point, and we have the distal cortical territory. If we look again at the vertebrobasilar injection, you can see that there's vessels that are missing over here. This one, carotid artery aneurysm. I think if we just looked at that, it would be easy to call it a PCOM aneurysm. This looks like a PCOM artery, except the vessel is wrapping around the midbrain and going medially. We don't see the normal PCA territory over here. If we look at the PCA territory, we may be missing some temporal lobe branches over here. This patient had two aneurysms, an ACOM that needed to be clipped. This one was coiled. We felt that that territory was lost. Patient didn't get a deficit. Had to have the ACOM clipped because we didn't know which aneurysm had bled. And this is the operative view. Carotid artery, there's the coiled aneurysm. A1, M1. And what I wanted to show you is that this was definitely an anterior choroidal, because if we clear this blood over here, you'll see the PCOM artery down here. There's the PCOM. Oh. PCOM artery, anterior choroidal artery over here. Choroplexus papillomas are tumors that are in the pediatric group. They're obviously highly vascular tumors, really difficult to operate on. That's the only treatment for them. And the patients are really at risk of bleeding tremendously during the surgery, so they're a good target for embolization. Here's the intra-cath lab angiogram, and what I wanted to show you was this. So here's the AP view carotid rim. This is the anterior choroidal artery over here. There's the blush of the choroid plexus. And you can see here on the AP view, microcatheter in the anterior choroidal artery up to this point over here, with the yellow arrows pointing at what? It's the PCA. So we saw that at the level of the lateral geniculate and the tectum, where the inferior tectal and superior tectal arteries used to meet, that's an area of anastomosis between the anterior choroidal artery and the posterior cerebral artery. This is an injection right at that point. And what we're seeing is the anastomotic vessels at the level of the lateral geniculate filling the posterior cerebral artery. If we look at that on the lateral view, here's the microcatheter in the anterior choroidal artery. Here's the choroid blush of the tumor. So this is where the choroid plexus is. And there's the posterior cerebral artery filling. Normal posterior cerebral artery. So it's really good to know that there's that anastomosis there. And if you're in the anterior choroidal, there's not just the risk of the perforators if you embolize, but there's the risk of getting into the PCA. That isn't always the case. Here's another PCA, anterior choroidal choroid plexus tumor. Here's the lateral view of the angiogram over here. Vessels are all absolutely straightened because it's a young child and there's hydrocephalus. But you can see the PCOM, PCA, anterior choroidal, and that anterior choroidal tumor blush. On the AP view, we've got the anterior choroidal over here, going up to the tumor blush. Microcatheter, lateral, AP, and we're obviously nicely past that geniculate anastomosis point because we're not getting any PCA filling, and it's a target for embolization. So that at the end of the embolization, the tumor's gone. So we've looked at the lateral geniculate anastomosis, and the last bit to look at, of course, is the choroidal anastomoses that take place. So this is an example of a patient with an AVN, choroidal AVN in the third ventricle. Very confusing angiogram, but let's just start by looking at this picture over here, which is the anterior choroidal artery that's dilated. Comes up all the way around to the foramen of Monroe, just like in the true limbic arch, and then supplies the AVN. If we go to this picture, which is a vertebrobasilar artery injection, so we've got medial choroidal perforators and lateral choroidal arteries going towards the supply of this choroidal AVN. And of course, the vessels are all coming up towards the foramen of Monroe and anastomosing at this point over here. So we've got anastomosis throughout the choroid plexus, right up to the foramen of Monroe. And then finally, the carotid injection on the right side, showing the anterior cerebral artery coming all the way around the corpus callosum back towards the foramen of Monroe to anastomose with the anterior choroidal artery. So true limbic arch persistence. And Carl's showing you this picture, and what it's really showing is the origin of the anterior choroidal artery, lateral geniculate anastomosis. We come around here all the way up to the foramen of Monroe, where we have the anastomosis with the limbic arch, the anterior cerebral, and anastomoses with all the other posterior choroidal branches, medial and lateral. Thank you. Any questions on anterior choroidal? I think Philippe's going to show you some pictures now. Yeah, get your microphone.